Hello, and thank you everyone for coming to today's event on kids, teens, and COVID vaccines. I'm Kira Peikoff, and I'm the editor-in-chief of leaps.org, a nonprofit initiative that publishes award-winning journalism about innovation, ethics, and the future of humanity. Our mission is to rebuild public trust in science as a force for good, and to reckon with the ethical implications of new breakthroughs. It's published by Good and Upworthy, and we're very grateful for program support from Leaps by Bayer. We're delighted to partner with the Aspen Institute Science and Society program for today's event.
Hello, I'm Aaron Mertz, and I'm the founding director of the Aspen Institute Science and Society program, part of the Institute's broader Health, Medicine, and Society program. Science and Society was established in 2019 with the mission to elevate public trust in science and to help foster a more diverse and a more engaged scientific workforce. The program is grateful for general support from Johnson & Johnson, the Rita Allen Foundation, the Kroll Charitable Trust, and the Smart Family Foundation of New York. I am also welcoming the audience on behalf of the Sabin-Aspen Vaccine Science and Policy Group, which brings together senior leaders across many disciplines to examine some of the most challenging vaccine-related issues and drive impactful change. This event is brought to you with generous support from the Gordon and Betty Moore Foundation and the Howard Hughes Medical Institute. The format of the event will be rotating conversations between two of our panelists at a time, as illustrated in this image. They will engage with a prompt question and then have a freely flowing conversation for 10 minutes, at which point Kira or I will come on to say that our time is up. Then the first speaker will drop off and will be joined by the next speaker. The pairings continue until speaker 4 and speaker 1 converse. Then we will bring all the panelists back at the end for Q&A fielded from the live chat, the Q&A feature at the bottom of the screen where you can submit questions, as well as questions that were submitted in advance when you registered.
For our first paired conversation, we'd like to welcome Dr. Dele Davies, who will interview Dr. Insi Yildirim. Dr. Davies is the Senior Vice Chancellor for Academic Affairs and Dean for Graduate Studies at the University of Nebraska Medical Campus. He is an internationally recognized expert in pediatric infectious diseases and a leader in community health. And Dr. Yildirim is Associate Professor of Pediatrics and Infectious Disease Specialist at Yale Medicine. She's also Medical Director of the Transplant Infectious Diseases at Yale School of Medicine, an Associate Professor of Global Health at the Yale Institute for Global Health, and she's a vaccinologist and investigator from Moderna's clinical vaccine trial for phase 1 adult and phase 2 to 3 in children 6 months to 12 years old. Our speakers can take it away.
Thank you very much. Thank you very much, Kira. And thank you to everybody for joining us today. I'm going to start off by interviewing Dr. Yildirim, and I'm going to just address you by your first name, Insi. Yeah. So thank you. So Insi, you know, we had this great news this past week about the CDC and the FDA approving the 12 to 50-year-old vaccines for children. Can you explain to our audience why we always wait to test new vaccines in younger children till after they've been tested in adults? And why don't we just extrapolate the results from older children and adults to younger children?
Thanks for the question, and thanks for the opportunity to have a chat with you about vaccines. It's a pleasure. In fact, you know, that is the common approach. We usually start with the adults for first in human studies, more with the drugs, but with the vaccines. But we have examples of vaccines such as pneumococcal vaccine or polio vaccine, where we did not wait for the adults to get the vaccine, and then we completed phase 3, and then we went to the younger age group. But I think there are many layers to it. One of them is obviously, if you're a parent and if your infant is getting a vaccine, and if your pediatrician asks you, do you want the needle to go to her or his arm, or do you want to get the needle? I think most of us will say, I want to get the needle. So there's that, concern about including younger ones and the family acceptance, obviously. But also it comes to the epidemiology of the disease. With the COVID-19, when we started phase 1 with the NIH Moderna trial, our target was young adults and, adults, not elderly. But as we have, went through, as we have seen how the mortality and the burden is more in the elderly, we extended our participants to those who are 65 and older.
Thank you. So could you then maybe elaborate on, are there sometimes, some unusual side effects that you might see in children that might not show up in an adult trial, which is another reason why we want to make sure we test in children?
I think, we as pediatricians, we all kind of agree that children are not little adults.
Okay.
They age, their body weight, their height changes, and as they grow, their immune system also gets more mature, and it varies. So the reactions that you're going to get from a 17-month-old baby can be completely different from a 25-year-old young adult, but also can be completely different from someone who's 15 years of age. So I think with the safety as well as the immunogenicity and the effectiveness of the vaccine, you have to have smaller age groups and have the data to have the vaccine that would give the optimal protection. The other reason you really do need pediatric vaccine studies is we do have a routine immunization schedule for our children, and we want to make sure that there is no interaction between the vaccines that we are studying and the vaccines that are already in the schedule to impact the benefit of the vaccines for the other infections that we are looking at. So there are many specific nuances that we need to figure out for the pediatric age group. It starts with the dosing, it starts with the safety, and it starts with the other vaccines that we are giving to our younger ones. I hope this answers the question that you asked.
Absolutely, it does. So I have another question for you. So, the two companies, Pfizer and Moderna, have now released information on 12 to 15 and 12 to 17-year-old age groups, and altogether they have about 6,000 children who have been enrolled, which is a lot, obviously, for pediatrics. Could you explain the difference in the kinds of studies that are being done in that age group? Like, what are we trying to show as opposed to in adults, where obviously hundreds of thousands of adults were enrolled in the studies?
So the studies are looking at the safety specific to these age groups, for sure, that's one. And the safety concerns may be similar to the adults in terms of what we are specifically looking for, and we will follow them for a year. But in terms of the immunogenicity of the vaccine, we have the antibodies that are specific to certain parts of the virus, as we have looked at the adult data. But since our outcome, as defined in the adult studies, which is the SARS-CoV-2 infection, either severe or mild infection, will be likely less common in the pediatric age group, I think we will end up using some sort of non-inferiority, or at least comparing to young adult population, meaning the immunogenicity data will be compared to those who are 16 and above, 16 to 25, instead of looking at this COVID-19 disease itself in the pediatric age group.
Excellent. And my understanding is that for those two studies, the children of 12 to 15 and 12 to 17 produced as good or as strong antibodies as the older
Exactly.
adults.
So what we have seen from yesterday's ACIP meeting, where the company presented the data, that was the first time we have seen the data, but it shows that it is 100% effective to prevent clinical disease, and the antibody concentrations are higher than the young adults within the same vaccine study. And the safety profiles are similar or even better than the younger adults. For the Moderna study, we have not seen the data, but the press release tells us that they have similar results for the same age group.
So thank you. And just to make sure that we clarify for our audience, so when we talk about the fact that it's effective, that means that between the two groups, right, they had children who got the vaccine and those who did not. And all the disease or the infections, actually in this case, that occurred in the children who got the placebo, who did not get the vaccine, correct?
Yeah, exactly. It was 100% effective by that definition. Exactly.
So this is really exciting for
It is.
us.
It
Not
is.
too many vaccines that we can say we have 100% effectiveness, or even 96%.
Yes, that's a very the mRNA vaccines which we have under the emergency use authorization. They have been terrific in terms of their safety profile and in terms of their efficacy so far.
So if we have another minute, just something that, some people have been asking about is pregnant women and whether or not, pregnant women should get this vaccine. Do you have any comments on that?
So this is a very challenging question, and there are many layers. We did not include pregnant women to the clinical trials, phase 1, phase 2, phase 3. And there are many reasons for it, but we ended up having no data for pregnant women, among pregnant women, when we had the emergency use authorization. And then, pregnant women ended up deciding whether they will get the vaccine or not to get the vaccine because it was not a contraindication. But it is all about risk and benefit, in a pandemic where you're pregnant and when you have the risk to get COVID-19 as a pregnant woman. I personally would be very comfortable to get the vaccine. And so far, there are thousands and thousands of pregnant women who received the vaccine under EUA, and there's no safety signal that should be concerning so far.
Correct. Excellent. Well, so, let's talk about the younger age groups for a minute. So we have, obviously the vaccine is now approved for 2 to 15-year-olds. Could you talk about, what you're aware of studies that are going on either at your institution and others that involve younger ages?
So there are at least 2 studies actively enrolling in the United States and Canada. These are the mRNA vaccines. One of them is the Pfizer vaccine. The other one is the NIH Moderna vaccine. And the age groups are as young as 6 months. So 6 months to 12 years of age is the age group for the Moderna trial that I am one of the investigators. And the study design, the vaccine is the same vaccine that has been used in older kids and the adults, but the dosing is different. So there are 3 different doses, and there are 3 different age groups within that 6 to 12 years of age. And the overall design is age de-escalation and dose escalation, meaning you start with the older kids with a lower dose, and when you see that that lower dose is safe in the older kids, you go up in the dose in the older kids, and you go to younger age group with a lower dose. And there are many safety checkpoints, so our pace will be a little bit slower than the adult studies because we want to make sure that the safety has been reviewed. There is a pause after a certain number of enrollment to look at any safety signal before going into the next step. And again, the goal is to have enough data to be presented to FDA at the end of this year or early next year so that they can go through a complete review. It is not going to be, FDA already has stated it, it is not going to be an amendment to the current emergency use authorization that the FDA has for current vaccines.
Well, thank you so much for those great answers. And I will turn it over now to Kira, I guess, to introduce our next conversations.
Thank you so much, Dr. Davies. This is Aaron again. You will come back later on. Now, Dr. Yildirim will interview Dr. Emily Oster. Dr. Oster is a professor of economics at Brown University. She is a best-selling author and parenting guru who has pioneered a method for assessing school safety. And the two of them will converse for about 10 minutes.
So I'm very, very happy to have this conversation, and I'm very excited as a pediatrician to hear what you're gonna say, Emily. So as a parent and someone who obviously has, have been thinking about this decision making processes, could you tell us what you think about having a new vaccine in your kid's arms? Like, what do you think about, and what makes you decide one way or the other?
So, I mean, I think for me, I'm very comfortable with the vaccine. My kids are 6 and 10, and when they are, when those vaccines go under EUA for kids that age, in the fall, I anticipate vaccinating them. I am like broadly in favor of vaccines. I talk to a lot of parents though, and I think that one of the things that's really coming across that is something we're going to have to grapple with in this decision-making space, is that there are a lot of parents who themselves were tremendously eager to get vaccinated with the mRNA vaccines, who in other domains of vaccination are very eager to get their kids vaccinated. People who tell me, like, of course I had my kid vaccinated for measles. These are not people who are nervous, sort of like generally nervous, but I think here they're kind of finding themselves almost like uncomfortable. There's almost a sort of cognitive dissonance around, okay, I'm a person who loves vaccines, and yet I'm having trouble getting myself over the line on these. And I think that the concerns sort of arise in a few places. I'm kind of interested in what you're hearing about this, but I think what I hear is, one, well, kids are low risk. And I think we have been telling people kids are low risk, and they are low risk. I mean, it is for most kids are low risk, especially much younger kids. And so they're sort of saying, well, I don't really see I'm struggling to see the personal benefit much here. And then at the same time, it feels like, okay, it's new and we don't have a lot of years of experience with this. And what if there is something? And I think that a piece of that is that when we make these choices, we tend to be weighing risks and benefits. And I think it's true that the risk benefit calculation for my 10-year-old is different than it was for me, certainly different than it was for my like immune compromised mom, right? And so I think that's kind of to say that those are all the same decision. They're not all the same decision. They may all be the same outcome, but we're going to need to help people work through that. And I think we're going to get to a place where reasonable people are going to have differing views on this.
Nicely said. Do you think that the speed of the trials and how we got to EUA is a factor?
A little bit, but I think that in general, people are very confused about the difference between EUA and full approval.
Yeah.
And I think that was like somehow not well understood. And the fact that it's a new kind of vaccine, I think sort of pulls on people. And, there's the conspiracy theory version of like, it changes your DNA, but then there's just the more basic version was like, I don't really get it. Like I understand when you have the smallpox, I understand the attenuated virus, like I understand you, but this is like a totally different new thing. And sort of oddly, I think for some of us who are like so into the science, there's a feeling of like, I don't think you understand how amazingly cool this is. Like these mRNA vaccines are like extraordinary. I mean, I heard a podcast with the CEO of Mrna, back in December, and I just couldn't believe how cool it was. But I'm not sure everybody's reaction is quite like that. And I think we struggled a little bit to help people understand that. The conversation you just had with Dr. Davies, I think is a very helpful one we're going to keep having, which is to try to help people understand, how do we evaluate safety? How are we going to move from adults to kids? Because now we're at a point where a lot of adults, by the time we get, particularly doing little kids, but even now, millions and millions and millions and millions of people have had this vaccine. So we do have a lot of kind of adult safety data, including adults who are, 16 to 18. How do we help people see that that's reassuring about 12 to 15, and then subsequently that that's going to be reassuring about younger kids? I think there is a sort of place for information there.
I think I totally agree with you in terms of how we could have communicated better within the pandemic time and the pace. Even, with the mRNA platform, it is not a brand new platform. Like, we have been working on it. We had human data starting as early as 1990s. But again, this is the year many of us heard about it for the first time, and it looks like, we could have communicated better. Another question for you. Do you think, as a parent, do you think that your kids should be vaccinated to go back to school in person?
No. So I mean, I've spent my kids will be vaccinated, and I think that it will be helpful for some pieces of school reopenings that we will have vaccines, particularly for high school kids. But I actually worry a bit about any rhetoric around the idea that kids would need to be vaccinated for safe in-person schooling. We have had in many places in America, we have had safe in-person schooling all year, including in the fall when there was no vaccination of anybody. And certainly sort of moving into the spring, we've seen more and more school reopenings with vaccinated teachers. And so that is a lot of protection, and more vaccinations for kids will enable us maybe to relax some of the kinds of things that we're doing in schools, distancing and so on, although some of those things we can probably relax anyway as case rates go down. But I think it would be it's quite important for policy that we not frame school school return as something like you can't return until you're vaccinated. I think there will be no appetite for doing that in most places. Even in, say, private schools in places that like vaccines, I don't think that there's going to be appetite for mandating. There may be appetite for encouraging, for asking people to be tested if they're not vaccinated, something like that. But I don't think we're going to have appetite for mandating. We don't mandate flu vaccines, even though we know that kids actually get the flu, and so we should probably do that. But we don't do that most places.
Okay. I hear your concerns about mandate. It is a very challenging question as well. Like, we within our groups, when we discuss about it, there are multiple different ideas, and usually there is no one best answer for this question. Well, thank you. This was really very helpful, and I'm going to return it back to Kira.
All right, well, thank you both. And for our next conversation, Dr. Oster will interview Dr. Tina Tan. Dr. Tan is a professor of pediatrics at the Feinberg School of Medicine at Northwestern University. She's been involved in several vaccine survey studies that examine the awareness, acceptance, barriers, and utilization of recommended preventative vaccines. Take it away.
Hi, Dr. Tan. I'm excited to get to connect.
Hey, Emily, this is a real pleasure.
Okay, so let's get into it. So I think I wanted to ask first about vaccine hesitancy. And I know you've done work surveying people, talking to people. We know this is an issue in some pockets of adults. How big an issue you think this is going to be for parents and kids, and as we sort of go into the summer and fall?
I think that's a great question. As you know, vaccine hesitancy has always been around. I think because this is a new vaccine and there still is a little bit of a lack of understanding about how important this vaccine, the role that this plays in controlling the pandemic, that there may be more hesitancy to get this vaccine, especially since the vaccine has only been around for, a year. And I think there still is some data that needs to be collected. And people do have questions about the safety of the vaccine, which I think is what's driving a lot of the hesitancy. But I think the FDA's authorization of the Pfizer vaccine for the 12 to 15-year-old age group is very, very exciting, and really is an important step toward our ability to control the spread of the virus and really help kids and their family get back to some semblance of normal.
Yeah, I mean, I sort of always been drawn to the kind of, somebody was telling me vax to relax. That was like, this is our push to normalcy. I mean, do you think that's the question is like, what is the message here? Is the message do this because your kids will otherwise get sick? Is the message like, do this so they can have more freedom, so they don't need to quarantine if they're exposed? Or is it do this, like, which of these messages do you think is going to work?
I think it's a combination of all of them. We know that if kids get vaccinated, this is really going to allow them to go on summer vacations, to attend summer camps, to basically go to other types of gatherings and sporting events where parents don't have to worry quite as much about, is my kid going to get exposed to COVID, and will they come down with a more serious illness when they get exposed? I think, what drives a lot of people not thinking that COVID can be serious in kids is the message that's always been out there that, most kids don't get very sick from COVID. And in general, that's true. However, we do know that kids get COVID. Some of these kids can become very seriously ill with COVID. And, some of these kids have long lasting consequences after getting COVID infection. So I think the best way to protect children from getting COVID disease is to vaccinate them.
I agree with that. I wonder, I guess one of the things I think people have been struggling with some of the CDC messaging is sort of how much freedom, how much you differentiate between vaccinated and unvaccinated people. I think that particularly around kids, I think Walensky said last week, okay, for 12 to 15-year-old kids who are at camp, they don't have to wear masks. That's a little bit of a carrot, but there's still a lot of emphasis on continued to mask and continued social distancing and all of these pieces. And I think it has led people, even adults, to say, well, what's the point? It doesn't sound like this vaccine is very good to me. It sounds like I still have to do all the same stuff. How do you think about nuancing that message?
I think, the big message out there is that if you're fully vaccinated, you can basically relax some of the protective measures if you're outside. The problem is that we don't know who's vaccinated and who's not. So the CDC message was basically a general message, which basically said that if you're outside and you're fully vaccinated, you can be around other individuals that are fully vaccinated and not wear your mask. The problem is that we don't know who's vaccinated and who's not vaccinated. And so because of that, you really still have to maintain the protective measures in order to prevent you being exposed, you being exposed to COVID and other people being exposed to COVID. So I think right now it's very difficult because we don't have a high enough number of individuals that are vaccinated to really sort of embrace that particular, guidance that's been put out there.
Yeah, and I think it's sort of hard because you want to tell people, just hold on, like, I promise you'll be able to have an inside party with all your friends soon, but right now, like, don't. And I think that's just a hard message. So what do you think? I'm curious about sort of thinking forward to the fall. 12 to 15-year-olds in many ways are an easier population to think about because we've done 16 to 18, so we have like some evidence there. And this is a group that's out, they're doing youth sports. There's actually like a bigger public health reason to sort of push for vaccines there. When we get to the fall and we start, somebody's going to come into you and say, well, should I do my 3-year-old? Like, I feel like they're not going to get it. And how are we going to think about that? Do you think that's going to be worse, better?
I think it's going to be a little bit more challenging because we do know that in general, COVID disease is less severe in younger children. So they're more likely to either have no symptoms or very, very mild symptoms. The only caveat to that is that we do know that younger children can still transmit the disease to others. So, they potentially could transmit the disease to other individuals in the community who are unvaccinated, who may be at a higher risk for coming down with severe disease and its complications, or someone else in the family who was not vaccinated, who might have an underlying disease that could develop severe COVID. But, in general, yes, you are correct that it may be a little bit harder to get these younger children vaccinated, primarily because of what we've seen with COVID disease. However, we have also seen that there have been younger children who have gotten COVID disease and then had long-term consequences because they got multi-system inflammatory syndrome. So, I mean, yes, it's more rare, but it does happen.
Yeah, and I think we're gonna, it feels to me like there's gonna be a balance there of sort of not trying to use like inappropriate scare tactics and, being like, if you don't do this, your kid's gonna, and then at the same time saying, hey, like there are some good reasons, some good sort of social reasons to do this. So let me ask you one last thing, which
Absolutely.
is where should we be vaccinating? Where should we be vaccinating kids? There's we've got these big things, like you wanna do it in your office?
So right now, with only the Pfizer vaccine having received EUA, because of the storage requirements for the Pfizer vaccine, it's probably not feasible to be able to vaccinate individuals in a pediatrician's office, even though a pediatric office is probably the best place to vaccinate kids. So right now, because of the storage requirements, the Pfizer vaccine is being given in large children's hospitals and many of the mass vaccination centers that have been set up in the different areas of different cities. Even some of the pharmacies may be vaccinating the 12 to 15-year-olds.
Yeah, I know here we're doing them at the mass vax sites. So we'll see. All right, so I'm gonna stop there and pass it to you to interview Dr. Davies.
Perfect, thank you.
Thank you.
Thank you so much. Now, Dr. Tan will interview Dr. Davies, and then we will have audience Q&A. So Dr. Davies, welcome back.
Thank you. Hi, Tina.
Hey, Dele. So one of the questions that really comes up now is, what do you tell parents who are on the fence about vaccinating their kids, given that there has been no long-term data about the vaccine in kids that is available yet, and the fact that, kids, especially younger kids, are significantly less likely to develop severe COVID disease?
Yeah, no, that's a great question. I would say that we have to look at the totality of the picture of what's going on here. First of all, the vaccine has been given to hundreds, actually millions of adults, and shown to be quite safe. We don't have a long-term picture yet over years, but what we know about vaccines in general is that most of the side effects that occur within the first few months, and it's very, very unusual to have sort of long-term damage to children years after vaccines been given. So that's one thing to put in mind. Yes, it is a disease that's clearly less impactful in kids in terms of severity and admissions, but we have to think about the totality. We have a lot of children who've had a lot of behavioral issues as a result of this COVID, a lot of anxiety, a lot of depression, children who are not able to go to school. And I was talking to my 15-year-old daughter just yesterday, and she says, I just want my life back. I mean, she's going to be lining up to get this vaccine because she just wants to be able to do the things that she's enjoyed doing and she's not been able to do. Then you also alluded to MIS-C. This is this multi-system inflammatory syndrome that occurs in children, now in adults, we're finding, which is not common, but we've had about 3,000 cases in the United States, which is really for a pediatric disease of that kind. Actually, we compare it to something called Kawasaki disease. It's sort of the closest. Last year was more common in many places than Kawasaki disease. So that's a disease, that's a condition that can be quite debilitating. And we've also had about 300 deaths from COVID in children, which, if you think about the average flu season, we don't get 300 deaths in kids, and we still recommend the vaccine. So I think just looking at the totality of everything that's involved here, the continued opportunity to transmit, children at the beginning of the epidemic of the pandemic were only 3% of all cases of COVID. Now they're 22%. So they're sort of continuing to the reservoir now, even though the loads are much lower, the rates are much lower than they have been. So I think on balance, there's a very strong argument to be made. And I think both you and, Dr. Oster have sort of highlighted that in the previous conversation as well, as to why it's important for parents to consider this vaccine.
No, I think you bring up some really great points. One other question is, do we have a clearer picture about which kids would get more serious COVID disease and who might be more predisposed to going on to developing MIS-C?
We do not. So right now, we cannot tell which kids are going to be likely to get MIS-C than others. I mean, there's some things that we do know in terms of, there's some data coming out, both in adults and children, that, for children and adults who get COVID, there's some evidence now that anywhere from 10 to 30% of them have what we call long haul syndrome. So this is a situation where after a month after, the children and the adults are still having persistent symptoms. It could be significant fatigue. It could be something called brain fog, where they're just not thinking clearly. And in some children and adults, this can actually be significant in terms of kidney disease and other sort of underlying damage. There's more data in adults for sure in terms of long haul, but we're seeing this in children as well. And there are actually a couple of studies, both in United Kingdom and in Italy. These are studies that have not been peer reviewed yet, to be very clear. They've just been put on sort of blogs that people can read, suggesting that 13% of children in the UK between the ages of 2 to 11 and 14% of children, 12 to 16 who have had COVID have long haul, which means that they're still a long COVID, meaning that they're still having symptoms a month out. And so that in itself is something to be concerned about.
No, I agree with you. And recently there was a retrospective study that was published that looked at children that had MIS-C, and it seemed to point to a disproportionate amount of disease occurring in the Black and the Latinx community.
Sorry, sorry, absolutely, yes. There's definitely racial disparities. It's a lot of a disproportionate of MIS-C has occurred in African Americans and Hispanics for sure. I thought you were referring to pathophysiology of maybe some kind of tendency genetically or something that has been identified. Absolutely.
Yeah. Do we know with the kids that have long haul, do we know whether or not many of them go back to being normal despite suffering for many months with their symptoms?
Many of them and most of them seem ultimately to revert back to normal, but there's some that still seem to have persistent symptoms months after. And I believe in one study up to 120 days later, they were still having symptoms. And this particular study, as I said, has not been peer reviewed, but they claimed that 42% of all the kids who had long haul were still having them 120 days out, which is a big chunk.
So knowing all this, what type of message do you have for parents who are on the fence about getting this vaccine with regards to preventing COVID in their children?
So again, as I said, if you look at the totality, if you look at deaths alone, and if you look at hospitalization alone, you might say, well, there's probably, maybe not as strong a case has been made in adults. But if you look at the totality of everything here in terms of, the risk of your child getting MIS-C, and we can't predict who's going to be the child who's going to get the MIS-C based on any markers. If you look at the totality of, the wellness issues that I just described, and then also the fact that even, by the way, children who don't have any symptoms at the beginning have been shown to then develop symptoms later on after COVID, and then go on to long haul. So these are a lot of factors that to me suggest that, if I know that, for example, my child is answering to get the vaccine as soon as it's available to her. And I think that every parent should really think seriously about giving this vaccine to their child for this reason.
Yeah, Dele, you bring up some really, really important points, because I think when many people think about COVID in children, they always think about the fact that they don't die from the disease and many of them don't get serious disease. But, as you just pointed out, there are some kids who can have very mild to no symptoms with COVID and then, several weeks later actually develop some of the long haul symptoms or go on to develop MIS-C. So the best way to prevent children in general from developing COVID disease or getting infected with COVID would be to vaccinate them.
Absolutely. You know, the other thing that I'll just point out, Tina, is that, you know, the viruses need hosts, right? They need hosts to replicate.
Mm-hmm.
And, you know, the longer we have opportunity for those viruses to have hosts that are not, you know, that in which they can freely replicate and divide, the greater the chance that they're going to mutate and lead to variants that can then be quite severe. And so if you think about that, you know, many of us have vulnerable loved ones. We have the elderly, and even though they've been immunized, we don't really know yet. You know, the CDC now has 3 categories of variants, right? Variants of interest, variants of concern, and variants of high consequence.
Yep.
And so we don't know if we have this large on the immunized group of children who could become a reservoir for the virus to go in and now have the opportunity to, you know, to exchange genetic material to mutate, then there's an opportunity then for that to become the source of the next maybe pandemic, or even maybe not even necessarily a pandemic, but outbreak in the community. If you think about what's going on in India right now and how many, you know, millions and millions of people are being affected with COVID, and, you know, hundreds of thousands infected and thousands dying every day, you know, this is all felt to be due to a variant or one or more variants that have emerged in India and are much, you know, much more likely to be spread. We don't know yet whether they're more deadly, but certainly much more likely to be spread. So this is really the concern, is that the more we have herd immunity in the community, including our children, who represent about 23-24% of the population,
Right.
the less likely we are to have this opportunity for these viruses to get in there and become breeding grounds for variants.
No, you bring up a great point. And I think that's why it's going to be so important that now it's the 12 to 15-year-olds being vaccinated, but, you know, it's going to be important to start to vaccinate even younger children so that we don't get spread in the development of variants that could cause even more harm in the pediatric population. I want to just thank you, Dele, so much for the great information that you provided. And I'm going to turn this back over to either Erin or Kara.
Thank you.
All right, well, thank you, everyone. And now we will shift over to audience Q&A. So I invite all of our speakers to come back on with their videos. And I will actually ask the first question. So Dr. Oster, this one's for you, actually. So I'm the mother of a preschooler. I've loved all your books. I read them like the Bible as a parent, so really appreciate that. And I'm wondering how you approach decision-making around safety data for preschoolers. So the co-founder of BioNTech recently said that data for kids as young as 5 could be available as soon as late summer or fall, though the children in the studies are going to be followed for a whole year. So as a mom interested in this vaccine, obviously, how long term of safety data would you want to see for this age group before you would take your kid to get the shot?
Yeah, so I mean, I think, you know, for me, there's a few pieces of this that I would look at. So one, I'm actually trying very hard not to have this hypothetical argument with myself now until I see this. And so, you know, I do get a lot of questions about this. And on the one hand, I think that that's like, we should be thinking about this now. On the other hand, until we see the data, there is no decision to be made. And there is a sort of value in like waiting on the decision rather than thinking about it every day. But since this is my job, I kind of do think about it every day. You know, I will almost certainly, if the safety data looks good initially, be comfortable getting my kids vaccinated. I think that there is not going to be a definitive time at which you can be sure. And this is a lot of the kinds of counseling about decision making that I do when I write about this. Is people say, well, I want to wait till I can be sure. I want to wait till I can be sure. And unless you have a very specific sure endpoint, like I will be convinced if things look good at 6 months. So for some people, they'd say like, that's it. I've decided 6 months is a cutoff. And if like, I'm going to wait for the 6 months of safety data, and then that's going to be my time. Then I think that's fine. I think for many of us though, there's a feeling of like more is better, more is better, more is better. But that can lead you into some kind of decision paralysis where you think, okay, more like, let me just wait and wait and wait. But then in your mind, you're thinking, well, what if in 17 years there's some impact, and you're never gonna learn about that. And at some point, people need to make a decision weighing the costs, which I think Dr. Davies did a very good job, articulating, and the kind of benefits of doing this and weighing that. So for me, I think the answer is when I see the good safety data and the FDA has approved the EUA, I will feel comfortable doing it. If people feel like they're waiting for something, the main piece of advice I would give them is just say what you're waiting for. Just decide for yourself what is the amount of time that you need. And if the answer is 3 decades, then you kind of need to step back and say, well, does that mean that kind of means I'm never going to do this? And am I comfortable with that decision?
Thank you so much. I'm going to ask a question now to our pediatricians here. This one came in during registration. One of the biggest questions I get as a school nurse revolves around fertility risk and the vaccine, even though there is nothing that indicates vaccines lead to infertility. How can I discuss the normal risks of infertility versus the vaccine with concerned and hesitant parents or potential parents?
I could take that. There's been, hundreds of, well, I guess hundreds of millions now in the United States. I think it's over 100 million people vaccinated. And many of them, a lot of them are women. There's absolutely no data to support any kind of linkage to fertility. And this has been looked at. There's really nothing to connect any kind of fertility issues to any of the vaccines. So I would say that there's no evidence of anything to do with fertility right now. And there's really no biological plausibility as to why this would impact fertility, to be very clear, because typically, you might say there might be some plausible biological reason why a vaccine would impact fertility, but there's really nothing that anybody can come up with. So for a combination of those facts, I would say that it's not something to be concerned about.
Yeah, I completely agree with Dr. Davies. There's absolutely no data that points toward any type of impact on the fertility of women who receive the COVID-19 vaccines. And again, that's not how these vaccines work. So, biologically, there should be absolutely no connection between getting a vaccine and infertility.
Great. For the next question, we have an audience member who would like to know, is the durability of immunity expected to be similar among children, teens, and adults? And do children experience the same amount of immune response to vaccination as teens and adults?
I can take that one. So, we only know the time that we have been going through. And so far, we have data from phase 3 mRNA vaccine trials where we saw that after 6 months after you receive your second dose, you still have a nice immune response. But we don't know if you have the response after a year after your second dose, because we haven't gone there, right? Because it hasn't been that much. We have been getting vaccines since December 2019. But to answer this question, in general, the younger you are, the better immune response that you provide to the vaccines, meaning you get a better vaccine-induced protection. This is not including the extreme age groups. Like if you're an infant, it is different. But usually the younger you are, you do respond better to the vaccine to get protection compared to those who are like 85 and older. That's why we have vaccines with a higher dose in older individuals compared to young adults. And in fact, if you look at the data presented to ACIP yesterday, kids who are younger than 16 have higher antibody levels compared to 16 to 25. We don't know what the antibody levels are, but we could easily say their immune responses are at least as good as the young adults. And we will see how it goes with the younger age group, like 12, under 12. But for the teenager groups that we have the EUA as of yesterday for Pfizer vaccine, their response is at least as good as the other older adults.
Thank you for that response. The next question also came in advance. I'm hoping you can provide some insight into what life will look like for a family of 5 like ours, where the mother and father are fully vaccinated. The 12-year-old son soon will be, but we still have a 10-year-old and a 9-year-old at home who obviously are not vaccinated.
So I can take that one. You know, it's almost going to be like sort of a cocoon strategy where people are vaccinated that are around those individuals that cannot be vaccinated. So I think, you know, if you're going to participate in family events, as many people as can be vaccinated should be vaccinated, and you should be able to protect these younger children who can't be vaccinated at that point in time against COVID disease. In a school setting, you're still going to have the child wear a mask and, you know, practice good hand hygiene and, you know, have the desks 3 feet apart. But beside that, you know, I think they should be able to participate in other activities, provided that those individuals that are vaccinated do get back, and those individuals that can be vaccinated do get vaccinated.
Can I just weigh in to say, I think that this will also change some over time. So as we see case rates continue to fall with hopefully increased vaccination rates, we are going to be able to open up, or at least some people I think are going to feel that it is acceptable to open up to having unmasked kids around each other because the case rates are low. I mean, we've seen, you know, Israel kind of pretty fully reopen even with more or less no vaccines for kids under 16 because of the sort of high vaccination rates in older people. So I think we're in an intermediate space right now where a family like that is going to probably still, it's a good idea to keep taking precautions with kids that are unvaccinated, but I don't think that that's going to be true indefinitely. Or at least I think that I think what I would say is, looking at the numbers, reasonable people are going to differ about the kinds of precautions they feel they need to take with their kids once case rates are down.
Yeah, I think one thing that sort of throws a wrench into this is that we really need to keep an eye on the variants that are being, you know, that are circulating in the community, because this can actually play a major role in terms of, you know, the types of precautions that we take with the younger children that can't be vaccinated, because we know that these kids do get the variants and they're able to transmit the variants to other kids.
Yeah, we just need to weigh that against mental health.
Thank you both.
Another point to add to Dr. Tan's point is it also depends on how many adults are vaccinated as a nation, right? Currently, I think we have like one third of the adults who are eligible are fully vaccinated. And we are as strong as our weakest link. Like, you would have pockets of populations where the vaccination rates are even lower. And in those populations, I think it will be a little bit challenging for those who cannot get the vaccine to have the protection.
Great, thank you. And we have a question from our live audience about side effects in kids. Are the side effects that you're seeing in the trials similar to adults in terms of fever, headache, et cetera, and they resolve after a day or two? Or are you seeing any longer term side effects or issues with kids and the vaccines?
So again, the data that I have seen that was presented to ACIP yesterday for their detailed review tells us that the side effects, adverse events after the vaccine are similar or even better than the young adults, 16 to 25. The only difference is, I think, the local lymphadenopathy, which is, you get the vaccine to your left arm in a muscle, and then you're expecting to see some immune response. So that may be a lymph node under your armpit or a lymph node around your neck area, because that's the area that is responding to the vaccine. So that was seen in, I believe, 0.8% of the vaccinees, and it was 0.2% in the placebo group in this younger age group. But if you look at the same lymph node enlargement in the young adults, it was 0.4% compared to none in the placebo group. But other than this lymph node, which is not statistically significant, and it's an expected reaction after the vaccine, the safety profile was similar based on what was presented to ACIP yesterday by the Pfizer mRNA vaccine.
Thank you. Here's a question that came into our live chat. What messages are friendly to early adolescents? While parent communication and consent are essential, how important is it also to speak directly to adolescents in our communication strategies?
I mean, I can take that. I think at that age, it's extremely important to involve them into decision making. And I think it's, first off, it's important to find out, you know, what their thoughts are about getting the vaccine, what worries them about getting the vaccine, and then what they can expect after they get the vaccine in terms of their ability to participate in different types of events. I think that gives individuals a better idea of, you know, how to approach offering the vaccine to a 12-year-old or a 13-year-old. But I think it's really important to get their input as to what they think they're going, you know, what the vaccine is going to benefit them.
I would agree, you know, and I will just actually draw from my own personal experience. I have an adolescent at home, as I indicated earlier. And I know she's come home a couple of times where she's had conversations with her friends who are really worried about COVID, but their parents are not. And she's sort of had this conversation with them and sort of trying to figure out how they convey to their parents the anxiety that they feel about, you know, the virus and not, you know, not wanting to be left unimmunized. So I think adolescents are a very powerful group of individuals who have a strong voice, and they're rational. They read the news like we do. They listen, and they're watching shows that are talking about this. They can see what's going on around the world. So I think that it's important that we communicate with them directly, and the messages are ones where we work with them to frame it. So I think if we're going to communicate with the adolescents, we want to try and get their input on what they think. And you know, social media is changing all the time. What I thought was cool yesterday is uncool today. So I think just finding out from them, you know, where are you guys hanging out these days? Who are you talking to? You know, what's the latest slang? I mean, there's a lot of things that change every day. So yeah, absolutely. I think communicating with the adolescents and then getting their input on how to do it is key.
Thank you for that. Another question came in advance regarding schools. So once the vaccines are given full licensure and approval by the FDA, can and should schools require the vaccines for teachers and or students?
I think, can they, once they're fully approved? Yes. You know, I think that they can, you know, schools can do this the same way they require other things. And I think employers, there's some more complicated questions as to whether employers can require the vaccine while it's still under EUA. My sense is that the answer is probably yes, but it's not totally straightforward. Will they? I think some will, but not all. I mean, I've been on a lot of calls with superintendents who have said, you know, particularly from places where the broad vaccine hesitancy is a bit higher, who have said, you know, there's no way we would require this for students. I think they're a little more mixed on teachers, but I think that you know, I think we may see this, but not in the short term.
So this is another question that you may get, you know, a spectrum of answers. And I wonder what other members of the panel will say. So this is a question for those who have expertise in ethics, in law, and in vaccinology in terms of the medical piece of it, right? So I think during a pandemic, by ethical perspectives or law, I was told by the experts that it is doable. You can do it. Even with the EUA, when you don't have the full approval, because it's a pandemic. But will that be effective? Meaning, will people get the vaccine more? Or are there other ways to have more people getting vaccinated? That's a big question. If you look at UK, they have only one vaccine that is mandated, and it is hepatitis B vaccine for the surgeons. If you look at us, I'm a healthcare provider. I don't get my paycheck if I don't get my flu shot. So it is a mandate for me. And, you know, I don't have any problem with getting a flu shot for many reasons. But I don't know which way is the best way to deal with this question. I'm not answering the question here. I'm just providing the spectrum. There are other ideas that, you know, that may go against what I'm saying or what Emily has just said.
So Incy, I think, you know, you have a good point. One of the things to add to this is that sometimes the decisions are made by politicians, right? I mean, you know, for example, you know, our governor has come out to say, not necessarily that he's going to, but he's not in favor of any kind of mandate. Now, I don't believe that he's actually said he's going to stop people from mandating, but he's very, very clearly said he's not in favor of a mandate. And I think that throughout the country, we're going to see the influence of, you know, politicians, governors, legislators who are going to basically help make that decision. Right now, it's interesting that we have several of the Big Ten schools who have already been mandating vaccines.
Yeah.
And, you know, everybody's watching very carefully to see whether this is going to lead to litigation or how it's all going to go. But, you know, and I know, for example,
Cornell is already being sued.
Okay, there you go. So, and how that's all going to end up. So this is really, I would say, very turbulent waters. I don't know that we know the answer yet.
Yeah.
Also, this is.
I'm sorry.
I'm sorry. I didn't.
Dynamic time for this. I think the other thing that's going to have kind of an influence on whether or not this vaccine should be mandated is what happens with COVID-19, right? You know, does it become something that is endemic and circulates every single year, except we don't know what season it might circulate? So I think a lot of that too can play into whether or not this should be a vaccine that should be added to those vaccines that are mandatory for you to attend school.
Exactly. We have other vaccines like, you know, meningococcal vaccine you have to have. So this is not the first vaccine that you would need to have to go through those, you know, institutions. I think the unique aspect of this, it is an EUA, so it is not a full approval, but as Dr. Tan just said, this is a pandemic. Nothing is, you know, normal. So we'll see.
Thank you. The next question is from a viewer who wrote that their primary concern is for children under 16 who are immune compromised and at high risk due to congenital birth defects, or children with CHD and or chromosomal abnormalities like Down syndrome, and they're at high risk for COVID. Do you think there will be priority for kids with chronic diseases during the pediatric vaccination rollout?
So I can tell you here where I practice, there's not going to be any prioritization given. I mean, vaccine is going to be administered to those individuals that want it. However, I think that individuals with underlying conditions should strongly consider getting that person vaccinated because they are at higher risk for severe COVID disease. And many places should have enough vaccine because we've seen a drop-off in the amount of vaccine that's being uptake in the adult population, that kids 12 to 15 years of age with underlying diseases should be able to get a dose of the vaccine.
Yeah, I agree. I don't think that we're going to have the same problems we had earlier on with a vaccine shortage right now.
Great, thank you. And we have another question around school and young kids. What precautions would you take with a classroom of 20 preschoolers in an enclosed space, given that none of them can get vaccinated yet? And at what point will it be safe for students to stop wearing masks at school?
I don't think, my view is this is a very hard question to answer because we don't, like, first of all, it depends a lot on where you are in terms of like the COVID rates in the area, and also the age of the kids. You know, if you're telling me preschoolers are 4, then mask etiquette is okay. You're telling me 1-year-olds, you can't you can't have 1-year-olds wear masks, and so they can't wear masks. I think this is the school discussion has moved a little bit into this space now of kind of when can we relax mask mandates, and I think there's a lot of disagreement and very little data. It's actually something I think a lot of us are trying to work on now is, you know, how can we use variation in mask mandates from this school year to try to speak to, you know, what might happen next school year, but that's not done yet. But my guess is I'm like less conservative than almost anyone else on this panel on this dimension.
Well, and I think Dr. Tan, mentioned the word cocoon earlier, and I believe that as we start to, when we get to the 12 to 15-year-olds, and then the further we move down, the lower the risk is going to be to the really young children. Because again, think about, you line up 100 matches, that are dry. You light one up and you tilt it, and all the remaining 99, right, are going to pretty very quickly light up, and it's going to spread very quickly. But if you douse, every 2 or 3 matches or so with water, the more you can douse with water, meaning that they're immunized, the less likely if you were to light up one match that it's going to spread to others. So that's the whole idea around cocooning and herd immunity, is that the more people we can get immunized around those younger children, then the quicker everybody can get to normality, because they're not going to be exposed to people who have the virus. So they'll be able to sort of mingle more freely. And again, when is a good answer, because I think that's going to be determined beyond just science. I think there are going to be other factors that come into play as to when all that can occur. But I think that the quicker we can get more people immunized, the faster and easier those decisions will be.
Completely agree.
Thank you. Here's another question. What is your best estimate on when we can reasonably expect to start seeing kids under 12 get vaccinated? And will it be rolled out in categories or simply any kid under 12?
So I think FDA has already stated that it will be full review for those younger than 12, unlike the amendment that Pfizer BioNTech had, and I think Moderna will have through FDA. That will take longer. Also, the studies, they will take longer overall, not per each individual specifically, but the enrollment will be slower given the safety checkpoints, and there are other things to consider when you're scheduling their visits. But the goal is having a core body of data for FDA to start their review, as they did with the adult COVID-19 vaccines back in late fall last year. By the end of this fiscal year, this is again a press release from Pfizer BioNTech. For the Moderna, I think we're looking at early 2022 for that data to be presented to FDA. The study will be going on, but FDA can start their review process.
I think it's pretty safe to say that it's not going to be until sometime in 2022 that
Exactly.
younger children
Exactly.
under 12 could be vaccinated.
Thank you, Dr. Tan.
And just a follow-up to that came in from our audience live, do you think that this vaccine for kids will end up being an annual shot like influenza?
Well,
I think
go ahead.
Go ahead.
Well, if you just go by the information we're hearing from the CEOs of Pfizer and Moderna, it appears that we'll need a booster dose for sure. I think that whether it becomes annual will depend on what happens during the year after we've had this booster dose, whether we're seeing more circulating variants and whether we're getting mini outbreaks, et cetera, that are impacting lives, and what's going on globally. Because again, the more people in the world who are not immunized, the greater the opportunity for the virus to continue to mutate and to become, to become a threat to the United States. So it's not just about what we do here, it's also about what happens to the rest of the world because of planes, trains, and automobiles.
There's a follow-up question to that came in the live Q&A. It's a tough ethical one about vaccines still being unavailable in the vast majority of the world. So how do you justify vaccinating very low-risk populations like children in rich countries versus sending those vaccines to high-risk country, the higher-risk people in other countries that don't have access to them?
That is a great question. And I think many countries are really trying to put together efforts to contribute vaccines to these other countries so that we do get the populations in those countries vaccinated. But I think that's an ethical question that has always kind of existed, because we do know that the vaccine schedules for the different countries are different. And who gets vaccine in one country is very different from who gets vaccine in another country. So I'm not sure I can answer that question.
Yeah, yeah. Oh, go ahead.
So personal comment on this. Vaccines are the most successful medical interventions, maybe just second to clean drinking water. And in my mind, vaccines, independent from your geographic location or socioeconomic status, you should have access to vaccines. But we have this reality for any other vaccine, as Dr. Ten just mentioned. We are in a pandemic and we have a huge mortality and other burdens. We all realize it. But this is not really specific to COVID-19 vaccine, the question that you're raising. And it is a reality. We are all going through that. But I don't know if the answer to that question is not providing vaccines in a country where the vaccines are available, just to make sure that those vaccines are available in another part of the world. You should be working on making vaccines available to those in the other locations, independent from making those vaccines available to the kids in this country, because they are, in fact, facing the burden of COVID-19 in many different ways. Our teenagers they went through a year where they didn't have any stimulus that they would get from school. We have kids who are eating at school. They need school for many other reasons, not just for their, education, but they need basic needs that they are getting from schools. So again, reality, and I 100% agree with that. Vaccines should be available independent from your geographic location or socioeconomic status if you want to get them.
Thank you. We are out of time, and I want to thank our fantastic panelists for this very lively discussion, for sharing your experience and expertise today. We all learned a lot. And to our audience, we recorded this and we'll be putting it on YouTube later today. And I'll send out a link to everyone who registered so you can go back and watch it and share it with your networks.
And thank you again for all of your very thoughtful and nuanced answers. And to the audience, this was the second in our 4-part series on vaccines and their developments this year. So stay in touch with us at leaps.org and the Aspen Institute Science and Society program for notice about our next event, which we anticipate will be late summer or early fall. Thanks again, everybody.
Thank you.